Welcome back to the Expediting Change podcast. It's so much love that y'all continue to come back and give me love, watching my show, bringing it to you, talking about expediting change. I am super excited today because we talk health, wealth, and happiness, whatever order it is for you. But today we're going to get right into it with a gentleman I call my big bro, Joe. So I'm going to allow my big bro, Joe, to introduce himself, and we're going to get right to it.
Open my mind and try to reach yours. Ask myself, why is it you really want to preach, boy? I want to teach you.
Mari, it's great to be with you. I'm Joseph Wright. I am a pediatrician by training, pediatric emergency medicine physician by training, currently serving as the Vice President and Chief Health Equity Officer for the University of Maryland Medical System. But I would be remiss if I didn't reference the fact that Shamari and I worked together for 4 years when I was the chairman of the Department of Pediatrics and Child Health at the Howard University College of Medicine right here in Washington, D.C. Absolutely. And again, pleasure to be here with you.
Absolutely. Thank you. My big bro, Joe, is, excuse me, he's so humble. He said, I'm Joseph Wright. He said, I'm Joe. This is doctor. This is the chair. This is the man right here. So on this Expediting Change podcast, we are going to pick his brain today and start wherever he wants to start, because we've been having conversations, as he just said, over the past 4 years about discrimination in healthcare, healthcare systems, about patient-centered healthcare as opposed to doctor-centered healthcare. So I'm gonna open this up to be a little bit different than I would even normally do, as opposed to just asking a specific question. And I'm gonna say, Joe, where do you want to start?
Well, why don't we peel this back from the health system level? And I'm glad you mentioned that term, because that is what I'm currently doing. My job is to unwind and dismantle bias and discrimination and racism in the healthcare system. Mm-hmm. And so if we start there, I think we can peel back and frankly get into some of my personal challenges. Okay. As a professional, as a Black man doing this work. Yep. And get into a conversation there.
That's a bet. Let's get into it. Let's peel this onion back. So tell me, what is your top concern right now?
Yeah. So my job is to focus on equity in patient care delivery. And it sounds pretty straightforward. Mm-hmm. Of course, everybody ought to be afforded a level playing field when it comes to healthcare. Mm-hmm. However, there are decades, if not centuries, of systematic and structural barriers and impediments to that ideal. Mm-hmm. And right now, I am literally working on those practice guidelines and algorithms, what literally lives in the textbooks, what lives in the electronic health record that the providers use as a reference, what lives in the electronic tools is something called up-to-date, that every student, resident, and practitioner has available on their handhelds to help guide them in delivering patient care. And embedded in these tools are decades and centuries of the racism that has been, and I'll say, the pseudoscience that has supported the embedding of racism in the guidelines that actually result in the delivery of care and result in the disparities in that care. Justifying it. Absolutely. Absolutely. I'll give you one example. Yeah. So, and this is an example that has hundreds of years of history here. In 1781, Thomas Jefferson, considered considered an enlightened individual of his era, stated that the lung capacity in the enslaved was deficient compared to white slave owners.
Say that one more time, and also, how are we going to qualify that, Dr. Wright?
There you go.
Was he a pediatrician? Was he a scientist?
Not only qualify it, but I will tell you that this is documented, and this is something that we can get into when I talk about my own personal tactics and strategies and tactics. So if you go to the Library of Congress, there is a very well-cited treatise called the State of the History of the State of Virginia, it was called. And 1781 is when it was published. And this is among the premises that Jefferson cited in that treatise, that, again, let me restate, that lung capacity was deficient in the enslaved.
That's
compared
crazy.
to. So again, this is purely speculative.
One man's judgment.
However, this concept lived on and into the following century, the mid-19th century. Here you had slave-owning physicians who began to conduct
research, tests,
experiments, obviously unauthorized experiments on the enslaved on their plantations, and repeated the concept. And not only that, stated it with more quantitative certainty, that there's 20% deficiency in lung capacity.
So trying to validate.
Among blacks, trying to validate and substantiate. Again, using pseudoscience. I call it pseudoscience. But this lives on in the peer-reviewed literature. I found these statements. This is not Joseph Wright talking here. I am quoting literally from referenceable publications.
The information we
and
can
this physician who I'm talking about right now, Samuel Cartwright, a slave-owning physician in Louisiana, published several papers where he again justified and went on to talk about, get this, and I want to get this right for the listeners, that he went on to say not only was lung capacity deficient, but the remedy for fixing the problem was forced labor. This is, again, quote, these are quotes around everything I'm saying here is referenceable, and you can look it up yourself. So here we are, mid-19th century. This is now moving into what we would call the modern era of medicine. And if anyone has ever used a spirometer, has had to breathe into a spirometer to see how much air you can force into that spirometer as a measurement of your lung function.
I have crazy allergies, so that low.
That instrument, that spirometer, is race normed.
Wow.
What do I mean by that? The actual instrument, the machine, actually someone's going to look at you and say, well, I think you are X race or ethnicity, dial in that race ethnicity to the machine and create an equation based on that race norming. That race norming dates back to Cartwright, dates back to Jefferson. That premise, again, that unsubstantiated premise that race somehow is linked to lung function and lung capacity.
That's crazy. So you have an agnostic machine that is not AI, that is not learning, but getting its bias from the humans that are programming it.
Yes, and that had been programming it for centuries. So and now let me bring it to current state. In the pandemic that we are still in, there were decisions about access to therapies based on the attempt to quantify what someone's lung function was. So look, basically, if you're real sick, you get X medicine. If you're not that sick, we're going to hold off. And some of the after action study through the pandemic has revealed that there were circumstances where individuals were stopped from receiving certain therapies based on this race norming assessment of their lung function, which is now being debunked as not legitimate.
Wow.
And that there were clearly, and there's one study I'm thinking of right now in Hispanic men. This was published just a few months ago, where the judgment about what is normal lung function for that group of individuals was erroneous, and that they were denied therapies based on that assessment.
So let's talk about that, because first off, it's scary, but for individuals who we know aren't going to do the research, some okay, some not, but me or my family or anyone watching this podcast who doesn't have a medical background, what's the danger in this? What's the outcome for me? How does this negatively impact me and my family?
So, good question, and this is a question that I get most often. Is first of all, is the public aware of this? I have published extensively and written on this over the course of the last couple of years, and I'm happy to share my own research, which is again highly cited, highly referenced, so that anyone who wants to take a deeper dive they can go to the sources. What I am doing in addition to unwinding, I've given you but one example talking about the lungs. There's a whole host of other examples.
No doubt.
Well, I'll give one more that's important for folks to be aware of. But I will say this: we have to become educated, because there has been surreptitiously hidden history here. In other words, everything I've talked to you about is referenceable. You can go look it up, but it's been hidden in plain sight. And so we have to become schooled on what is the reality of, frankly, race-based medicine.
No doubt.
And let me just define that really quickly. When we say race-based medicine, we're talking about the erroneous use of race as a biologic proxy. Let me say that again. Race is a social construct.
Absolutely.
It is not a biologic construct.
Absolutely.
So when we incorporate race into clinical decision-making, we are assuming that race is somehow driving the biologic factors that produce disparities.
No doubt.
And that is a dangerous concept.
Dangerous.
And what has happened is that the incorporation of race as a biologic proxy has woven its way into the clinical decision-making, such that you can pick up one of these algorithms, literally go down the decision-making path, you get to a box that says race, yes, no, and decision is sending you a certain way. That's what race-based medicine is, when race is used as part of a decision-making or a dichotomizing algorithm. You make a decision one way or another based on a person's. And often, it is the race based on what someone assumes. They look at you and say, oh, I think, and make a decision.
Absolutely. And so, Black people are not a monolith.
That's right. Absolutely. Absolutely. And I'm going to come back to talking about chronic kidney disease in a moment, because I want people to understand that one as well. But you've hit on something very important. Folk of color are not a monolith. And when you weave in the history of genetic ancestry in this country, and the degree to which there is tremendous admixture, there is really no legitimate validation for the legitimacy of skin color as a determining factor in clinical decision-making for healthcare. And that's really what we're talking about.
That's crazy.
Here.
You gotta rewind that and listen to what he just said. That is impactful. But Big Bro Joe, I have the luxury of being able to text you, call you, or do our Silver Diner breakfast, right? But everybody does not have that luxury. And if you know, you know. And if you don't, you don't. So where does that person go? How do they start? What are they looking for?
Let me tell you something that's happening, and you know that I've grown up in academic medicine.
Absolutely.
That is where I've spent my career and where I generate my currency.
Yep.
For this kind of work is in the academic space.
Mm-hmm.
And I am happy to say that the work that I have published is available to the public. It doesn't live behind a firewall, it doesn't live behind a subscription paid practice.
Yeah.
So what have we been talking about here is available.
Mm-hmm.
It is available. If you were to simply Google my name, Joseph L. Wright, MD, MPH, this content would come up.
Okay.
This content would become available. And I'm glad to say, just jumping to where we'll be wrapping up this conversation, what I've been able to do is to get the attention of editors and journals who, look, those are businesses and they generate revenue based on subscriptions.
Absolutely.
And however, the importance of this work has not been lost on them. Mm-hmm. So the public access availability of literally everything that I published in the last year on race-based medicine is available to the public, and folks can actually just find it.
Absolutely. So Google Dr. Joseph Wright. But I want to get back to that though. Let's talk about the other example that you had. Let's get into that because folks need to hear. You and I have had the conversation, but the people need to hear it.
Okay, let me break this one down. Black folk in America have experienced a huge disparity when it comes to chronic kidney disease.
Yeah.
And when you peel back the etiology of that, you find something very interesting. That based on, again, an assumption rooted in pseudoscience, not based on in fact, has driven much of that disparity.
Mm-hmm.
An assumption that we as Black people have greater skeletal muscle mass than other people has led to an adjustment in the way that we calculate kidney function. Basically saying for you and I as Black men, well, your kidney disease is not so bad because you're a Black person, and we assume that the laboratory value, which is called creatinine, that the creatinine, which is abnormal in you, well, it's abnormal in you because y'all have greater muscle mass than everybody else. So we're not going to provide you access to advanced kidney care or a transplant if you should need it until you get sicker.
That's crazy.
That's basically the bottom line. So there again has been an adjustment made based on an assumption for a group of people that has rendered them at a place where when we present for treatment of our kidney disease, we are sicker, and in many cases, sicker beyond the place where we can get access to something like a kidney transplant should we need it.
That's right.
And so this is another example of race-based medicine where there is a decision made based on race, and this has been rooted, unquestioned in the medical literature and the way that we practice. Now, thankfully, there's been a great deal of attention on this particular race-based medicine algorithm, and I'm happy to report that health systems around the country, including mine, have dismantled the algorithm, eliminated the algorithm, and
so what does that countermeasure look like? Is that literally reprogramming the machine, deleting the algorithm?
It's reprogramming the equation, the actual laboratory. Your blood test goes to the lab, and the parameter of race is not there.
Okay.
Heretofore, race was a factor in actually running the laboratory test
Yep.
and determining the staging of your disease. Now, race has been eliminated from that process.
So, are there any laws surrounding it?
Oh my God,
I mean, because it almost sounds illegal, right? It's like when I go to fill out an application, check all that apply, or I don't have to check anything. So, are the health systems now mandated to not send the race, or is it just based off of their own decision making?
At this point, we are generating momentum across the landscape of the profession. We're big health systems. We are a 30,000 employee, 12 campus system. So when we make a move like that, people pay attention.
People see it.
So we did this announced it in November and actually executed on it in February of 2022. So, folk, I've been getting a lot of calls. Okay, how did you do that? How did you do that? Help me understand how we do that. But this is changing practice.
No doubt.
This is changing practice.
For the good.
Yes, for the good and leveling the playing field. So the proof in the pudding, the proof in the action will be this. Now we follow what happens with our folk relative to the access to advanced kidney care, to access to transplant compared to everybody else. And there should be no difference. Now, there's going to be a lot of catch-up time because we got a lot of sick people with chronic kidney disease who have not been afforded that access in the past. But moving forward, we are beginning to track how that playing field has been leveled, and making sure that race is not a part of the staging.
Should it be legislated?
Like, there are opportunities where legislation can help, and this is, for instance, newborn screening. Newborn screening picks up diseases based on a blood test in all newborns. And there are examples where this can be useful and hasn't really been acted on. And we have disparities that go undetected in Black babies. And I can talk about an example there. But to your broader question, we first have to just get people to practice medicine correctly.
No doubt.
You know, I hesitate on the legislation because we just got to teach the thing right.
No doubt.
We got to be objective. It has to be rooted in true science, not something speculative, not something that someone believes that is unsubstantiated, which has really been the root of how we got here.
So we got to crawl before we walk, which is inclusive of getting right before we even get to legislation, because we could get to legislation and it's just not right. So
you got to get the people. You got to get the people. Well, first of all, I am really heartened that the folks who have been pushing hardest here are the next generation of providers. The people, the students, the medical students and the health profession students across all disciplines.
That's dope.
And the folks who are in training right now, they're the ones who are pushing. They're the ones who are challenging dogma. Who are saying, I don't know about that. You got to tell me why race is appropriate here.
Absolutely.
And so it is transformational change, but it's also generational change.
Absolutely.
And so until, frankly, we get the curmudgeons out of the leadership roles who have been trained differently and where we are struggling to get that change to happen, this is going to be, we didn't get here overnight.
Absolutely.
And it's going to be generational work. Absolutely.
So like turning a cruise ship, not a speedboat. Right?
That's right. That's absolutely right.
So that's good on the end of the providers. But what can I do when I walk into my doctor's office?
You know, I think we, again, as consumers, we got to be educated. And I would direct people to be, ask questions. Hey, doc, what about that my chronic kidney disease.
Yep.
I understand that around the country that race has been taken out of the equation. Can you tell me about that?
Yep.
I think we have to push and challenge our providers, which is something that culturally we have not done.
Absolutely.
And we also have to really be aware. For instance, women of childbearing age. I'm going through my whole
Let's talk about
paper right now. Women of childbearing age need to be aware that just because they may have had a cesarean section previously, that they are not confined to having C-sections for the rest of their reproductive life. And why do I say that? Well, because one of the other race-based algorithms that I came across in our research has to do with the fact that Black and Hispanic women were less likely to be offered the opportunity for a trial of labor to deliver vaginally after having had a previous C-section.
They just automatically see
automatically
C-section
another
and just say,
that's
let's
right.
go C-section.
Let's go C-section.
Based off someone's subjective opinion.
Subjective opinion. And again, rooted in documentable but racist premises. I looked at a textbook from the 1930s and saw a picture of what is called a gynecoid pelvis. We're talking about the shape of the pelvis. And the gynecoid pelvis is the standard. That's the that's the white pelvis, the gynecoid pelvis. And anything else is less likely to result in safe vaginal birth. Delivery. Now, we've been birthing babies from time immemorial.
Absolutely.
And so
without knowing what it looks
exactly.
like.
And so, seeing this documented picture in a gynecology textbook, OBGYN textbook, was just more evidence that it reminds me of Chinua Achebe said, until the lion learns to read, the story will always be told from the hunter's perspective.
Absolutely.
So until we call this out, until we call, because this is, again, in plain sight. I didn't have to go far. Okay, maybe finding a 1930s textbook, it wasn't on my shelf.
Mine either.
But this stuff moves forward.
Right.
And when I saw that racialized science talking about the gynecoid pelvis and the non-gynecoid pelvis, the non-gynecoid pelvis obviously referring to those who are not white European standard. This has lived on in that particular specialty such that we had this algorithm that says, well, you know what? If you have had a previous cesarean section as a Black or brown woman, guess what? You are destined to have another C-section and another C-section.
That's just crazy.
And so, again, thankfully, the profession is waking up. And for the American College of Obstetrics and Gynecology, they have eliminated those parameters from that particular algorithm. Another move that our health system has made and that people are paying attention to. But to your point, when I say people paying attention, I'm getting a lot of attention from industry. We really need to emphasize this with the public.
Okay.
And so for women of childbearing age, particularly if you've had a previous C-section, ask your OB, your obstetrician, about the vaginal birth after C-section. It's called VBAC for short, vaginal birth after C-section. And have that conversation.
Absolutely.
And make sure that provider, that physician or their practice is attuned to what's going on.
So press them. I love it. So this question is the question I ask everybody on the Expediting Change podcast, because the podcast was created to talk about what are we doing, boots on the ground, where the rubber meets the road. But everything you just talked about is boots on the ground, rubber meets the road, right? So we still go ask the question, Big Bro Joe, talk to me about the practicality of it. Let me know how are you expediting change right now for everything that we just talked about?
Yeah, you signaled that this is where we were going to go with this conversation. And I've had some hard lessons learned myself. I'm passionate about this work.
Yep.
You know, I've been a Black man in medicine for 30 plus years.
No doubt.
So I've even struggled with, wow, I've been trained on these very same principles. Now, I'm going to share one vignette before we get into
No worries. Let's
the
go.
boots on the ground.
Yep.
I was a mid-career associate professor, very successful teacher here at one of the major children's hospitals. And when I first learned about Vivian Thomas, anyone who's seen the film Something the Lord Made, Most Def playing Vivian Thomas as a Black man who literally created the surgical procedure to correct the blue baby syndrome. And in a nutshell, the blue baby syndrome was basically a genetic abnormality of the heart that would kill babies. And Vivian Thomas, who is a carpenter by training, but a brilliant man who never had an opportunity, was taken on as a research apprentice by the father, who was considered, again, the father of modern surgery, Alfred Blaylock at Johns Hopkins. And in their laboratory, Vivian Thomas was able to develop the procedure and the instruments, because you can imagine operating on an infant's heart requires special instruments. So the cut to the chase, I was really incensed to not know about this, because I've taken care of hundreds of babies with this defect. And the Blaylock-Tausig shunt is the procedure, the surgical procedure. Now, you notice that it doesn't reference anything about Vivian Thomas. It's Blaylock, who is the white man, and Lynn Tausig, who was a cardiologist at Hopkins, white woman, who basically gave no attribution whatsoever to Vivian Thomas when this procedure was developed and the first baby saved in 1944, front page of then what was called Life magazine. Vivian Thomas is mentioned nowhere.
Whitewashed.
Yes, as I said, hidden history. And I was feeling some kind of way. I'm like, wait a minute. I've been taking care of these kids my whole career. I have been part of, I've been part of the hidden history. So personally, I have had to reconcile myself that I need to get even more steeped in knowledge and history.
No doubt.
And not knowing about having to see Something the Lord Made and Most Def tell the story to me, as opposed to every day. Why am I not seeing this in our textbooks?
I like hidden
Why
history.
do we not? Yes. And so that was inspirational for me. This was probably, that film was probably now 15 years old. But I would still commend it to folk because it is not only a story that tells about a pivotal moment in medical history, but you can imagine Vivian Thomas in 1940s Baltimore, the struggles that he had to really get the attention and do the work. But it was his tutelage that changed the face of medicine, because after that procedure was developed, there became the specialty of cardiac surgery, which didn't exist. The premise before that was that you can't operate on the heart. Well, guess what? Vivian Thomas turned that around.
No doubt.
So I say all that to say that when I think about the tactics and the strategies under those tactics, the tactics under those strategies that I have come to employ, it is an over attribution of fact. And what I mean by that is that we have to direct people to the source of these transgressions. We have to be very clear that this isn't something that is being made up.
Yep.
This isn't conjecture.
Yep.
This is actual fact, and I will take you to the source.
No doubt.
And I will show it to you.
Absolutely. Evidence.
So anyone who, again, Googles my name and looks at the work that I've written will notice that these papers, these articles,
yeah.
are highly cited and highly referenced so that folks can say, okay, I know where I can find this or I can direct you to it.
Absolutely.
And I think that's very important. That credibility is key.
Okay.
So that we're not talking in the subjectivity that they have enacted on us.
Absolutely.
The other tactic that I have leveraged is having people appreciate the value of differential lived experience.
Mm.
Now,
I call that diversity of thought.
You know, that sounds so simplistic, right?
Mm-hmm.
But
however,
I will tell you that even when I share bits and pieces of my own journey, folk are like, "What, Joe? Really, you?"
Yeah.
And you know, folks struggle if they have not been exposed to really appreciate the journey, the uniqueness of our own individual journey.
Yeah.
And so I have, you know, at some emotional peril, I will confess to that.
No doubt.
Leverage my own family history. And we are fortunate that we have been able to trace back again, factually, very factually, real, concerted, and clear lived experience in ways that point out a differential path for not only me and my family, but for others who work in diverse communities, and particularly in my field of pediatrics, there is no more rapidly diversifying segment of the population in this country other than children. Children under the age of 18 have already become the majority of that segment of the population. Let me say that again. Children of color have already become, and this was 2018. So there are more children of color than any other kind of children in the United States. And I think the projected date for the entire population to hit that threshold is just 20 or so years off.
Absolutely.
So, you know, I think we have to point these things out and not be scared to do that.
No doubt. Don't be scared.
You gotta be you just have to be very direct. And very factual. Now, I've had people get up and walk out of the room of my lectures, and you know, that's okay. That's okay.
Absolutely.
Another tactic that I use is to just flood the field with information. Just flood the field. I'm gonna keep coming at you,
and everybody's not gonna come along.
And that's fine. I currently am a board member of my professional society, and when we began this journey, pre-George Floyd, by the way, there was a colleague who said to me, "You know, we're going to lose members over this," and I said, "And and
can't be scared,
right?
Got to do the right thing.
So it's about truth. It's about reconciliation. You got to get people to reconcile in their own mind what they're hearing. And, you know, adult education theory says folks have to hear things seven, 8 times before it even...
I said that yesterday.
It even sinks in.
Leadership meeting yesterday.
Yeah. So we've got to be... we have got to be very deliberate and stay on message.
Truth and reconciliation.
And we can't get to transformation until you've taken those first steps.
Truth, reconciliation, and transformation.
You can't just leap to transformation until you get people's attention.
Absolutely. And
get people's attention with truth. And the reconciliation takes time.
Absolutely.
It takes time. Absolutely.
Big bro Joe, that was deep. Thank you for the work that you do. Thank you for coming on here to talk about it with us. Listen, podcasters, listen, audience, if it feels heavy, it's for a reason. If you feel some type of way, you should. Everything that Dr. Wright just said, we've had many of conversations about, but it still feels heavy to me, even though we've had these conversations. So we're a solution-oriented podcast, Expediting Change now. Dr. Wright said a bunch of things, but one of the key things I want you to walk away with is arm yourself. And I don't mean go get your guns. That's not what I'm talking about. All right, squad, don't get your guns. But maybe get your guns, but I completely digress. In this podcast, in this piece, what you want to do with arm yourself is with information. It's easy enough to take whatever it is going on with you and Google it. Put it in your phone and have it there so when you go to your care provider, you can have it in your phone to ask the questions based off what you researched. Now, everything on Google is not necessarily true, but let them validate that for you, right? So what we have to do, what we need to do as Black and brown people for the culture is be in a position where we are going to advocate for ourselves. Because if we want to be rich, if we want to prosper, if we want to be wealthy, then we have to maintain our health. And a function of that starts with our mental health to get into a position where we are going to advocate for our physical health. Dr. Wright, it has been a pleasure having you on the podcast today. This is Expediting Change, and please stay with us.
As I open my mind and try to reach yours, ask myself, why is it you really want to preach, boy? I want to teach more.